Good afternoon, everybody. I would like to thank the organizing committee for this invitation. I'm going to discuss today treatment of cholestatic liver disease in Alagille and PFIC. This is my disclosure slide. And my learning objectives today is to discuss the natural history of Alagille, what we've learned so far, and treatment of cholestatic pruritus, and discuss PFIC, treatment, again, of cholestatic pruritus and PFIC, and the lessons we've learned from consortiums around the world. And the last thing I'm going to cover is the IBAT inhibitor use in pediatric data. And during that time, I will cover the pivotal studies that have changed our understanding, our practice. Why should we all care? I do understand that most of you are adult hepatologists, but I hope I can engage you with this slide to tell you that Alagille syndrome is one of the more common inherited causes of pediatric cholestasis, but 40% of these patients survive into, 40% of Alagille patients will go into adulthood with native liver, and 90% of our patients will survive into adulthood. So you are going to take care of these patients. Also, Alagille prevalence is actually one of the more prevalent inherited genetic disorders. Prevalence is around 1 in 30,000, which is similar to Wilson's disease. And I would argue, I would converse with you that most of you know very well what to do with patients with Wilson's disease. How about PFIC? PFIC, although they are rare inherited disorders, actually now we know that heterozygosity might confer increased risk for liver disease. So hopefully that engaged you enough. Sorry. And we're starting with Alagille. Alagille is an autosomal dominant disease caused by mutations mostly in the JAGED1 gene in 95% of the patient, and less commonly with the NOTCH2 gene mutation. Prevalence, again, is 1 in 30,000. And traditionally, we used to define Alagille as it's a bile duct paucity. And you had to meet 3 out of the 5 criteria that are listed before, which involves cholestasis, the characteristic feces, and other. Or you could have a family history with 1 more criteria. Or on rare occasions, you have all 5 criteria without the genetic mutation. Nowadays, in 2026, we can all agree that probably a JAGED1 pathogenic mutation, the pathogenic is very important to note here, or likely pathogenic, can define Alagille syndrome without the clinical criteria. And in the past decade, we've had more studies, and we have, treatment for cholestatic pruritus. I'm gonna, in the next allotted time to me, I'm gonna cover data that we've learned in the last, 5 years probably, that have changed how we view things. So the Global Alagille Alliance Study Group, which is the GALA study, was very important in our understanding of this disease. And it was the first consortium of many centers around the world. But the difference between the GALA study group and other published data from the children and other networks is this involves all hospitals, not just tertiary care centers. So many pediatric centers involved in the study were regular, real life patients. And this was involved in 28 countries around the world. This was a retrospective data collection. And obviously, there is a certain bias because this is a hepatologist-based study. So 1,433 patients had clinically or genetically confirmed diagnosis of Alagille. 85% of those patients had a history of neonatal cholestasis. And this slide is a little bit busy, the table, but this is to say that now we know this was a new publication just published in December. There is a phenotypic difference between JAGED1 and NOTCH2, with the JAGED1 having more penetrance of the traditional symptoms we think about. Obviously, all of them have the liver involvement. Sorry, go back. And can you see it or no, I have to? Okay, no. Sorry. All of them have liver involvement and have the same native liver survival, but characteristic facies, posterior embryotoxin, bone disease are different between those two phenotypic diseases. From the GALA study, we learned that 40% of children will reach adulthood with their native liver. And we learned early on that total bilirubin between 6 and 12 months of life has prognostic indication. So if your total bilirubin was above 10 during that time period, you had an 8-fold increased risk of developing clinically evident portal hypertension and 15 times increased risk of liver transplantation relative to patients, infants with total bilirubin less than 5. Also in that study, we learned if infants had Kasai or a surgical biliary diversion, they have worse outcome. But now we probably know they probably had a severe, more expression of disease. This study came out also last year, is very important, and now we're learning about serum bile acids and how they can affect clinical outcome. In this study, they looked at the serum bile acids in these patients. They had, out of the 1,400, 560 patients were included in this sub-analysis, and those 50% of this cohort had at least 3 measurements of serum bile acids. But the conclusion of the study basically said serum bile acids positively, moderately correlate with total serum bilirubin, which is not a surprise to anybody, but they are actually more sensitive in predicting outcome, because there is a subset of patients that will have anectatic cholestasis, meaning bilirubin considered as normal but high serum bile acids. The other thing we learned from this study is that time 0 in this graphs is the time at last clinical visit. Serum bile acid, those that don't do well will remain elevated over time, and the level is 1 or 2, and I will go back to that in the PFIC data. Serum bile acids remain elevated over time versus the total bilirubin, although it might improve initially right before event like transplant or events, it will be much higher. And serum bile, if we use it as a dichotomous value in the Kaplan survival curve, serum bile acids above 1 or 2 will predict worst outcome and will predict event-free survival. The primary indication for liver transplant in Alagille syndrome is due to persistent cholestasis in actually 72% of the patients. And obviously its secondary consequences, which include intractable pruritus. Alagille and PFIC2 are one of the most cholestatic diseases we see in children. And again, everything consequences of persistent cholestasis. But mind you, 50% of these patients that went on to go to transplant had more than one indication. Graft survival, once we transplant them, they do excellent. And again, they will go to see you in the adult world. So now I hope I engage you enough to say Alagille matters to you. It is something you will see in your clinical practice. It's common. And we can predict survival, and serum bile acid matter. So now I'm gonna switch a little bit gears, talking about the ileal bile acid therapy, the inhibitors, and what we need to know and the data that support their use in pediatrics. So these are selective reversible inhibitors of the ileal ileal bile acid uptake inhibitors. They're orally administered, minimally absorbed, and when we use them, we're going to decrease serum bile acids and secondarily reduce the serum bile acids and reduce intrahepatic bile acid, which we think is what causes the pruritus. This first study that was involved the use of marilixibat is really a pivotal study, the iconic. It was a randomized withdrawal study design with long-term open label follow-up. They had patients use open label treatment with marilixibat, then they were randomized for 4 weeks marilixibat or placebo. And then they went back into an open label extension with marilixibat and long-term. The primary endpoint was a change in serum bile acids from weeks 18 to 22. In this study, when they stopped maralixibat use, all of the patients had rise in serum bile acids and pruritus, and when they restarted on the medication, they had improvement of symptoms and reduction in pruritus scores, and this effect persisted later on. The block graph tells you that the severe pruritus, to be enrolled for these studies, you had to have at least moderate pruritus, which is score 2 to 4, and most of them had improvement in their itch on the treatment side. The adverse events and safety, you can see here, there is from the PFIC trial, it's the same, but because of the ICONIC trial was only for 4 weeks during placebo control, we use this data, which is the same. Primary side effect for both the IBAT, the odevixibat, and the maralixibat basically are almost the same, with mostly GI side effects, as you would expect, because they're inhibiting the uptake of bile acids, abdominal pain. Most of them had very rare serious side effects, but both can cause serum transaminase elevation, and bone fractures and decrease in hemoglobin. There was no treatment-related death. The study that evaluated use of IBATs in, this is also a pivotal study using odevixibat. This was double-blind randomized placebo-controlled trial where they enrolled 52 patients with either odevixibat or placebo, and same thing. Change of caregiver reported scratching was the main primary outcome. Of note in these patients, sorry, I'm gonna go next. This is again the assert, I will get to that point. You have better outcome using the IBAT therapy with improvement in serum bile acids and pruritus. Does this matter? Because the indication for IBAT as of 2026 is still pruritus, treatment of pruritus. It's not treatment of the serum bile acids or liver disease. This, I put it after the studies because they compared a cohort treated maralixibat patient, but this cohort, it wasn't just the GALA study or the ICONIC study, which had limited number. They had 83 patients, and they matched them with the GALA registry, and they matched the patient, and actually patients were treated with maralixibat fared much better and survived better. Now you can argue the reason we transplant these patients is because of cholestasis and pruritus. So if we're treating the pruritus, then it obviously makes sense that they are staying with their native liver disease, native liver for a longer time. Odevixibat adverse events is basically the same, very well tolerated with mostly GI side effects. Okay. To put a plug for patients with Alagille syndrome that go into adult, I included 2 manuscripts here that are pretty resourceful. The one thing need to know here is there is a risk of HCC in the adult world, and it doesn't have to exist with cirrhosis. So the recommendation for the adult world is that you should screen for HCC in all ages in the adult world, regardless of the severity of hepatic involvement, and the recommendation is to do a yearly ultrasound and serum AFP every 6 months. Moving on to PFIC. PFIC is a group of autosomal genetic disorders which result in disruption of bile formation and chronic cholestasis. The most traditional are the PFIC 1 to 3, but now we have so many of them. And beyond 3 and 4, the EASL recommends just use the genetic mutation better for understanding. None of us remember after the many numbers after. They're all low GGT except MDR3. PFIC 2 is the BSAP, bile salt export pump deficiency, and this is the most common. That's why I'm just comparing PFIC 2 and PFIC 3. PFIC 2 causes severe cholestasis similar to Alagille, very bad pruritus, and increased risk of HCC. And PFIC 3 is the high GGT. It can present anytime, even in adulthood. If you have heterozygosity, you have increased risk of cholestasis. In pregnancy, you can have low phospholipid-associated cholelithiasis and more increased risk with DILI with certain drug. If you have residual activity, these patients respond 70% to URSO. And the reason I mentioned that is most of the studies that I'm going to cover with PFIC involve PFIC-1 and PFIC-2. Very few one involve PFIC-3. So the NAPID consortium is also multi-center international studies that looked at the outcome of PFIC, that's type 2 only, after surgical biliary diversion. And in this study, if you have the BSAP1, 2, and 3 is how much you have residual function of that transporter. And if you have a truncating mutation with no transporter activity, then you had worse outcome. You had shorter time to transplant, and you had a higher risk of HCC. But very important from the NAPID consortium, they were the first to say that if we reduce bile acids after surgical diversion by 75% or to less than 1 or 2 millimoles per liter, you had better outcome. In this study, the truncating mutations did worst. This is just a cartoon. Basically, IBAT therapy is the equivalent of a surgical diversion. And we're going to cover 2 studies with the PFIC. The PFIC-1, the NAPID, this is the same, saying that if your bile acids are decreased to less than 1 or 2, you had better outcome. And we understood with the PFICs, which is very different than the Alagille, if we look at the genotype, in many cases we can predict phenotype, which is very different in Alagille. Okay. The odevixibat were the first study to treat patients with PFIC. This is a randomized controlled placebo trial. The same patients that received IBAT fared much better and had less itching. And all primary outcomes were related to the itch. Marilixibat, again, in the PFIC, this was a multi-center randomized double-blind controlled placebo group. In this, again, they had, in this study, they included all PFICs, not just PFIC-1 and 2, but non-truncating mutations of BSAP were not included in this analysis. And the same results. The PFIC Indigo study is different because they did include truncating mutation and they included the other PFICs, that tie junction mutation and other. And again, there was good outcome, but in truncating mutation, if you have no bile acids getting to your gut, it's not going to work. They did not have good outcome. So, summary of the IBAT therapy, we have, I'm not going to read the slide, but basically we can treat patients above 3 months of age. They're very expensive. And just a plug for all of you is that the EASL guideline on genetic cholestatic disease strongly encourages genetic testing in any patients with chronic liver disease of unknown etiology. And in the EASL guidelines, they tell you that IBAT therapy is up there for both peds and adults as a treatment option. This is my concluding slide to tell you, I hope I shared with you that Alagille is autosomal dominant disease with without genotypic predictors versus the PFIC group of patients. They have a clearer genotypic-phenotypic correlation, but heterozygosity might confer increased risk of disease, and serum bile acids and response to therapy matter. And IBAT therapy, we know now, are approved for pruritus, and we know they decrease serum bile acids, but we need more data for possible road beyond pruritus. Thank you for your attention.
Thank you, Dr. Voss, and I really would like to thank the organizers for giving me the opportunity to update you on some new exciting things related to this disease, biliary atresia, and I will end the presentation emphasizing some areas for transition to the care as adults. Here's my disclosures. I'm going to briefly talk about the importance of this disease, its etiology, some new information about the diagnostic pathway, emphasize treatment and transition. So biliary atresia is defined as a complete fibrotic obstruction of extrahepatic bile ducts within the first 3 months of life. It's really a phenotype and not a disease. The phenotype is very characteristic, as you'll see in a minute, but there may be multiple pathways to this final phenotype. It's characterized by pale or acholic stools, hepatomegaly, and jaundice, again, within the first weeks of life. Direct hyperbilirubinemia and elevated GGT are the characteristic biochemical findings. Overall, of all infants, which is about 1 in 2,500 infants, 40% will have this specific disease, far outnumbering all other causes of neonatal cholestasis. It's absolutely fatal if untreated, with biliary cirrhosis and liver failure occurring by 2 years of age. There's roughly 300 to 350 new cases each year in the United States. It's about 1 in 10,000 to 1 in 15,000 live births. And interestingly, although it's, quote, congenital, it's very rare for siblings or even twins to have biliary atresia. So we can tell families it's extremely unlikely to recur in the same family. And importantly, 40% of liver transplants performed in children are for this single disease. The biliary atresia can involve any portion of the extrahepatic biliary tree, and you could see it here. I don't think I have a pointer. Right? But any portion, proximal, distal, gallbladder, cystic duct, or the entire extrahepatic biliary tree. And this just shows you an excised biliary tree from an infant with biliary atresia on your left, and on the right is the histology of one of these extrahepatic bile ducts. This bile duct is yet to be completely obstructed, but further up down the bile duct it was. There's concentric fibrosis, necrosis of biliary epithelium, and inflammation as the characteristic findings. And what's unusual about this disease is after the extrahepatic tree is extracted during the Kasai procedure, which I'll show you in a minute, there's continued progression of the intrahepatic disease. So those who've been around for a while, this used to be called extrahepatic biliary atresia, but it's actually the intrahepatic portion of the disease that leads to the progression and death and or liver transplant, since the extrahepatic portion is removed. So we just call it biliary atresia at this point in time. Now, Sunny Harpavad, who's going to join us up here in a little bit, and others have shown that biliary atresia appears to be a prenatal insult. Used to be said it was perinatal, but virtually all cases have elevated conjugated bilirubin shortly, within days of birth. Therefore, some have called this now a developmental cholangiopathy, and perhaps there's a prenatal virus, toxin, vascular insult on top of that, and clearly there's an aberrant immune response, like I showed you in that liver biopsy, that occurs after birth. Many patients also are shown to have an absent gallbladder on prenatal ultrasound, again, confirming the prenatal occurrence. And as I said, conjugated bilirubin's elevated at birth. So there's a paradigm that's developed with various genes that predispose. Some may actually cause biliary atresia, like PKD1L1. This, combined with some perinatal insult, is felt to create the necrosis of the biliary epithelium, the inflammation, and the fibrosis. The treatment of biliary atresia is quite standard now, and it's the Kasai hepatoportoenterostomy, where a loop of intestine is placed where the bile duct is removed, and hopefully there's small bile duct radicals that will drain into the Roux loop. The best results now are clearer if the child has a surgery before 30 to 45 days of life. After 90 days, the results are quite a bit worse, and after 120 days, most of us won't even proceed to Kasai, but rather proceed to a primary liver transplant because the results are so poor. So 70–80% of patients may develop a good bile flow after this procedure, clearing their jaundice. But even with jaundice clearance, at least half of those infants will develop progressive fibrosis, biliary, intrahepatic biliary obstruction, and need a liver transplant. And you can see that on some of these curves. This is a large series from France showing survival with native liver, so transplant-free survival, based on the age at the Kasai operation. And you can see the yellow line at 30 days has the best outcome, but even with the earliest of Kasai operations, there's still many who fail to drain bile within the first few months of life, or a gradual drop-off over time in the requirement for liver transplant. But still, it's very important to make the diagnosis early, and the real challenge is the fact that many infants, because of breast milk-associated jaundice, physiologic jaundice, develop jaundice in their first few weeks of life. And the best outcome for the Kasai is early on in life. This overlaps with the period of indirect hyperbilirubinemia. So the real question is, how do you identify a cholestatic infant with all the noise of indirect hyperbilirubinemia happening literally at the same time? And there's at least 300 to 400 infants with indirect hyperbilirubinemia compared to those with cholestasis. The average pediatrician in their lifetime will probably see 2 patients with biliary atresia, and in any given week, they've got many kids in their practice, infants who are breastfed, et cetera, who are jaundiced. So the idea is to develop either a newborn screening or an early screening in the first few weeks of life for cholestasis and biliary atresia. Various things are under investigation, including looking at conjugated bilirubin in the first few days, or measuring at 2 to 3 weeks of life, and looking at the stool color early on in life. This is becoming popular in Asia, in some other countries, but has not been piloted successfully yet in North America. So the attempt here is to actually educate the primary care providers who see the infants in the first few weeks of life. They see all these jaundice infants, to try to educate them about when to investigate for cholestasis. And it's very simple. All the children really need is a conjugated or a direct bilirubin, because it should not be elevated in those indirect hyperbilirubinemia cases. So a group put together this recent guideline that was published in the journal called Pediatrics, and it's really a clinical guidance for primary care providers about when to look for cholestasis. And it's very simple. At the 2 to 4 week well-child visit, they should look at the eyes for icterus, the stool to see if they're acholic, and check and see if the child ever had a prior conjugated bilirubin before they were discharged as a newborn. And again, Sunny Harpavad has led this group. They've even got a website now to make it even easier. And really all the primary care doctor has to do is to plug in the answers to a few questions to see if they need to pursue a direct bilirubin and see if the child has cholestasis. I'm very hopeful that this is going to help make the diagnosis earlier, but I also am very skeptical that the primary care providers, of which there's nurse practitioners, PAs, doctors, many others, family medicine doctors, whether they're actually going to adopt this, but this is the best chance that we have now to make an early diagnosis. So I just want to quickly go through how we make this diagnosis of biliary atresia. And in general, we start with a child with neonatal cholestasis. So first you have to identify that they're cholestatic. Biliary atresia is one of the first things we always think about, in a combination of an elevated GGT, perhaps an absent or abnormal gallbladder on ultrasound, and other testing lead to the need for IOC, which is an intraoperative cholangiogram. If it's biliary atresia at the cholangiogram, they get a Kasai operation. That's been the typical way we've done this, and you could see down this algorithm, this is the classic way we've done this, is genetic testing for some of the diseases we just heard about are done later on in this algorithm. And now with the widespread use of genetic treatment, and this is some of the biochemical workup that would be typical in the classic algorithm. But more recently, we've moved genotyping up in this algorithm such that if the child does not have biliary atresia or some other common cholestatic diseases like alpha-1 antitrypsin deficiency, then many of us will get a genetics panel for cholestatic diseases. What I wanted to point out mainly here, though, is to shift the emphasis onto biliary atresia. We now have a couple of newer tests that are less invasive than an intraoperative cholangiogram, and that is the blood test, MMP7, and something called PTCC, which is percutaneous transhepatic cholecystocholangiography, and I'll show you some examples of both of these. So MMP7, matrix metalloproteinase 7, is a protein that's expressed by injured biliary epithelium, and as you can see in this diagram on the left, children with BA in general have much higher levels than non-BA cholestatic infants. These are all infants presenting with cholestasis, and on the right shows you the ROC curves with area under the curves of 0.9, which is quite good, but it's not 100%. But what this does show you here is looking at two separate assays, and this was a very large study, 400 infants you could see, that there is a very high negative predictive value of the MMP7. So if it's normal, the chance of the infant having biliary atresia is virtually zero. So it's not a bad test then to decide who needs to get a cholangiogram and who does not. The problem with the MMP7 test is every single lab has different cutoff values, even using the same assay. So it's become an issue as to where to send the test and whose normal values to believe. Also, very early in infancy and in preterm infants especially, it's elevated, not exactly clear why, but that confounds interpreting the results. And if you have to make a decision about sending a child to the operating room for a Kasai operation or getting that PTCC that I'll show you in a second, you need rapid turnaround. You can't wait a week or two for these results because, again, we want to have surgery before 30 days of age. So, assuming that one makes the decision that this could be biliary atresia, in the past we'd send the child to surgery, get a cholangiogram, intraoperative. However, nowadays, with interventional radiology being as skilled as they are in pediatrics, they now can perform both a cholangiogram and a liver biopsy through the liver, backside of the liver into the gallbladder percutaneously. This avoids the intraoperative cholangiogram. There's a good safety profile with experienced radiologists. A gallbladder has to be present because that's what they're sticking the needle in. So if there's an absent gallbladder and there's no lumen at all, they cannot do this, but then the patient needs to go to intraoperative cholangiogram, and roughly 60-70% of the time this is successful. So this shows you in an infant with cholestasis, PTCC here, that shows normal biliary tree. Here's one that shows absent extrahepatic distal bile duct, the common bile duct, and very abnormal intrahepatic bile ducts. This was biliary atresia, and here's one where the cystic gallbladder is just a dead end and there's no communication at all. With the biliary tree, that's also biliary atresia. Now, I did want to just show you a newer modification on ultrasound that came out of Dr. Harpavad and his wonderful ultrasound tech. And what they decided is to look longitudinally to see if you could identify the common bile duct in infants. Normally, when we do the ultrasound looking for in the cholestatic infant, we discount when the radiologist says they can't see a bile duct because it's so small. but we've always done this with fasting, like you would any abdominal ultrasound. What they did was decide to feed the infants, and lo and behold, the common bile duct and common hepatic duct show up because bile starts flowing. And without going into all the details, they've developed this technique where the bile duct can be seen, and if you look between 3 and 4, you can see a long duct. If it's over 3.5 millimeters, then it's considered normal, and this child does not have biliary atresia. So you can just do an ultrasound to decide who needs to go to surgery and who doesn't. This is what you see with biliary atresia, and you see no common bile duct. So a number of us are trying to adopt this at our sites as a way to non-invasively, again, decide who needs to go to surgery and who doesn't. Treatment of biliary atresia currently involves, again, the Kasai portoenterostomy, primary liver transplant if they're too old, and if they have progressive disease that doesn't respond to the Kasai. Medically, we have very little therapy that's effective, nothing that's FDA approved. We always treat the children with ursodiol. There's not a lot of data showing it affects their long-term outcome. We prevent cholangitis. We take close attention to their nutrition and fat-soluble vitamins. Pruritus is less of a problem in biliary atresia than it is in PFIC and Alagille syndrome, but there are still patients who itch, and we use rifampin and other therapies, antihistamines, etc. There is a very large phase 3 trial going on right now with an IBAT inhibitor, odevixibat, for biliary atresia, and the results should be out sometime later this year. So we're all anxiously awaiting, and it really is not based on treating pruritus, but changing the course of the disease by reducing the bile acid pool size and bile acid load that's presented to the liver. Steroids after the Kasai operation are controversial, and I'll just leave it at that. And then finally, for PPAR agonists, which we've heard about here before, we're going to hear more this afternoon, and FXR agonists and others, there's very little data in biliary atresia, although I just found this paper that was published last year where 10 adults surviving with their native liver with biliary atresia had a bezafibrate, a PPAR agonist trial. And among those 10 patients, they received 2 doses for 12 weeks of bezafibrate, which I assume is a standard adult dose. You can see the ALK phos did statistically fall and remained low for the 12 weeks. 24 weeks was off therapy. GGT lowered, but that was it. Nothing else changed, AST, ALT, bilirubin, etc. Interestingly, 1 out of 10 patients developed rhabdomyolysis. 4 out of 10 developed cholangitis during the trial, which may have just been the natural history of the disease, and they showed some changes in serum bile acids, although the total serum bile acid level didn't change. So this is the only data I could find of PPAR agonists in biliary atresia. The rhabdomyolysis, which my understanding is very unusual in adults treated with PPARs. Here you got 1 out of 10 adults with biliary atresia having rhabdomyolysis. Now, since there will be a group of children surviving into adulthood with their native liver, and that's on the right side of this curve, and many surviving into adulthood who've had a liver transplant for biliary atresia, adult providers, hepatologists, APPs, and others are going to have to care for these patients. So there's a list of concerns that you should all be aware of. Some of these aren't a big surprise in somebody who has chronic liver disease like portal hypertension, but ascending cholangitis is quite common in these patients. Also fat-soluble vitamin deficiencies, osteoporosis. Interestingly, HCC is relatively rare, but it does occur. Minimal hepatic encephalopathy is certainly still an issue, and many of them have behavioral and emotional issues that they carry with them from this childhood of having a chronic disease. So there's been a couple of papers published on identifying a transition program, which really needs to start in the early teenage years, the yellow arrow there, and then between 16 and 25 years of age, where the parent, guardian, and the adolescent need to be treated equally, and then clearly after 18, 20 years, perhaps 25 years, the patient really needs to take over their own health care like other adults. And this may sound straightforward and easy, but it's not. This just talks about some of the things that are necessary: medication, sexual health, substance misuse, psychosocial issues, the parent-child interactions, and non-adherence, particularly after transplant. So, that completes my presentation, and I just want all of you who come from a winter snowy environment to send snow to Colorado. We desperately need it this year. Thank you.
All right, that was fantastic. So now we have some time for questions, and while you all are thinking about it and coming up to the mic, I'm going to go ahead and introduce and invite our panel to come up. Dr. Nitika Gupta is from Emory University, professor of pediatrics and director of liver transplant for Children's Healthcare of Atlanta. Dr. Sunny Harbavat is from Texas. It actually doesn't say your institution here, Sunny. Texas Children's, I was going to guess that. He's a pediatric gastroenterologist, hepatologist, and associate professor. And then Dr. Mercedes Martinez is a professor of pediatrics. There she is, yes, thank you, at New York Presbyterian Stanley Children's Hospital in New York. Also pediatric transplant hepatologist. So we have a fantastic group here. And we'll go ahead to the mic over here.
Hi, I'm Kris Kowdley, advancement fellow at CHLA.
Little
Guys, Hello? There we go. Okay. Hi, sorry, I'm Harry Sutton. I'm the liver transplant fellow at CHLA. I have two questions. Coming from a center that didn't have MMP7 to now a center that does, my experience this year has been that almost all of them are indeterminate, that like there's this very, very big indeterminate range, and I found it difficult to kind of interpret that and how much do I take a high indeterminate versus a low indeterminate, and I'd be interested in what people's experience is with these indeterminate results. And then my other question for Sunny is, I know the hilum, the ultrasound with the duct at the hilum has been, I think, really impressive, and we've used it on 2 of our patients at CHLA. Is this something that takes special training? Like, is this something that I can bring to my tech and say, this is what we're doing, or do they need to meet with your team, or how, what's the best way to facilitate it?
Good. You want to do the MMP7 first? So.
No, repeat the question for me. What was it?
Oh, sorry. The MMP7 is just about what you do with these indeterminates. Like a lot of the results are in between the negative and the positive, and just what do you do with a 35? And you just feel like, does this help you in any way?
Indeterminate for biliary atresia diagnosis.
Essentially using an MMP7, they give you the number, and it's in this big indeterminate range.
MMP7 is borderline, and the ultrasound is, there's a small gallbladder, and just sort of these combinations of tricky results. So
we don't particularly use the MMP7 to guide our care because we can't get the results quick enough. So we would use more the patient's course, the color of their stool, liver size, et cetera, to determine if and when we do the PTCC. And we've gotten quite aggressive over the last few years, given our confidence that our radiologists can do this procedure safely. We used to do the percutaneous liver biopsies, and now we let the radiologists handle both of them at the same time, so we get a tremendous amount of information with one anesthetic rather than two, and we've saved numerous children from getting an intra-abdominal exploration for the IOC. So if they have any gallbladder remnant with fluid in it that the radiologists feel they can pierce and do the PTCC, and again, assuming platelets are okay, etc., then we'll generally proceed fairly rapidly to that, and then get genetic testing if that's negative, and test for a few other diseases along the way.
Some nodding. Yeah, go ahead.
I want to make a comment. I actually use MMP7, and I would encourage the use as one piece of the puzzle. I think it's very helpful if it's negative, but there have been, at least from personal communication, at least I know of 3 cases in the country where we've had stone cold normal MMP, not in the equivocal range, that had biliary atresia. At least one of them had not a complete obliteration of the common bile duct. So I use the MMP7, especially when I have time on my side. If I have somebody who's like closer to 4 weeks, in our institution we don't do PTCC because we're not as good with it. We usually go to the intraoperative cholangiogram. But I do find it very helpful, and sometimes in the premature babies where it's not BA, but also there is no room for error because it's a time-sensitive diagnosis.
Yeah, we actually don't use MMP7s. We kind of follow what Ron just alluded to. I'll request it, like if I'm seeing a cardiac baby or there are multiple other things, and it's, again, one piece of the puzzle, but I've never made a decision to proceed with a PTCC or not based on an MMP7, and I don't think it should be used in isolation. I don't know if you're ready for that prime time, but we have great IR docs, and we have a low threshold. We'll go straight for PTCC and a liver biopsy. And it has really changed the way we practice. We've really prevented a lot of kids from going for surgery, and you get a great diagnosis. PTCC is done in the morning, you have your answer right then, you wait to see what the biopsy shows. I think if you have IR expertise, this is a great tool.
That's fantastic. We'll go to the mic over here. Kathy.
Well,
Mike.
can you hear me now?
Now we can hear you.
Now, okay. First of all, I want to thank the organizers for the focus on pediatrics. It's just terrific, and Dr. Sokol and Fawaz for the wonderful talks. Also, I think it's just great to have such a tribute to Bruce Bacon, because when I was an assistant professor of pediatric gastroenterology at St. Louis University, I went to Bruce's lab, and he was a fellow and I was a fellow, and I think, Dr. Sokol, did you not do the same thing?
I did the same thing.
I thought so. So just wonderful to hear these words of tribute to him. Also, I would like to make a pitch for the organizers next year to include the kind of cradle to the grave approach in one session, because we pediatric hepatologists have so much to learn from adult hepatologists, but vice versa, and whether it's hepatitis B or C or biliary atresia. So I think that might be kind of a novel, important, real-world focus. And then I want to take the opportunity to get a free consult from these distinguished hepatologists, because right now at Rady Children's in San Diego, we have a 5-month-old baby with Alagille syndrome, very severe cholestasis, very severe failure to thrive, and a large VSD that needs to be operated on, but he can't be operated on yet because he's so malnourished. So my question is the role of IBAT inhibitors in the presence of very severe malnutrition secondary to cholestasis, because he may get diarrhea, which may make the malnutrition worse, or his liver disease may improve. So what do you think? I need opinions from the experts.
Well, first of all, sorry about the challenge you're having. We would probably be treating this patient with parenteral nutrition. I don't know if you're doing the same, but if you're having a difficult time, but we've been very aggressive with patients with biliary atresia and other cholestatic diseases to treat them with central lines and hospital and then convert to home parenteral nutrition if we have no other way to improve their nutrition, particularly if they're awaiting a liver transplant. So if you want to grow them so they can receive a liver transplant, that's what we would do. I think the labels actually on the IBAT inhibitors say not to use them with decompensated liver disease. So if this child's decompensating, I actually think it's contraindicated. Although I don't know that there's data to show that it's dangerous, but that's what the label says.
Though some of their, I think, initial studies, not in decompensated patients, but in other patients, did show improvement in growth. So, but
Right.
not in a decompensated.
Reading all the fine print, it's really hard for us to figure out benefit or liability. We have no argument with the aggressive nutrition, however.
All right, thank you.
Okay, thank you.
Thank you, Kathy. So we're gonna see if we can jump through a couple cases. So this is an infant born at 35 weeks to a 35-year-old woman with severe preeclampsia, noticed to be jaundiced at 3 days, elevated GGT, and had the classic phenotype of Alagilles with a butterfly vertebrae, broad forehead, pointed chin, and ASD was diagnosed. Sent home on ursodiol and fat-soluble vitamin supplements. At 2 weeks of age, came back for ileal strictures and was genotyped was Jaguin, and then discharged again. However, at age 4, came back with xanthomas. And I don't know if you want to just speak about this briefly, Ron, since this was your patient.
But these xanthomas, which involved all extremities, all fingers, toes, eyelids, not nostrils, so the child could breathe, but earlobes, elbows, etc. I haven't seen xanthomas this bad, and you could see the cholesterol was 1,500 or so. And we were headed down a path considering liver transplantation in this child. This was back before IBAT inhibitors were approved. And since this child had advanced liver disease, we didn't think that a partial surgical biliary diversion would be of help. We haven't had great luck in Alagille syndrome with those anyway. So that was the decision point. Is there something we can do?
Great. So Sunny, how commonly do you see xanthomas like this? Like, is this a typical presentation?
Yeah, so we usually see it in the setting of Alagille syndrome, as this patient has, and we see it probably in a proportion, not in every patient for sure, but certainly this is a place where the PBC world, I think, and the adult world, the hepatologists, the lipidologists, and the pediatric world, these mysterious kind of growths on the hand and the digits, it's totally disfiguring, it prevents the use of the digits. And what I find interesting is that LDL at 774. For other reasons in pediatrics, when we see an LDL of 774, we think of a autosomal recessive disorder where the body can't clear LDL, but this is actually a trick because this isn't actually LDL. This is lipoprotein X, which has the same density as LDL, so traditional laboratories can't distinguish between the two. So these patients are Alagille's patients, though they do have heart disease, usually developmental heart disease. They aren't developing atherosclerosis at age 4 or 5, despite these high levels.
All right. Quickly, thank you. Quickly, Mercedes, how would you treat the child?
Well, one thing that I will do for this patient is, did anybody check the apolipoprotein B? Because that is what will make the difference for you to know if this is lipoprotein X or this is a real LDL. Then very important to check that. This child, if he has a lipoprotein X, he will not respond to lipid-lowering medications because most of the lipid-lowering medications are targeting apolipoprotein B. And the treatment for this child is the treatment of cholestasis. You need to treat the cholestasis to improve the lipid and to improve the symptoms. There are at least, and I think that Dr. Sokol mentioned the IBAR inhibitors. We know that the IBAR inhibitors will improve the cholestasis, will likely improve the lipid, and there are at least 2 case reports in JPGM last year where 2 patients with severe symptoms, even an extreme case with symptoms in the airway, those patients significantly improve after the treatment of IBAR inhibitors. Then it's very important to know if this is lipoprotein X. For us in pediatric it's very easy because most patients with cholestatic disorder that have this level of LDL, unless there is a family history for homozygous familial hypercholesterolemia, I think that this patient have an elevated lipoprotein X, and what is needed is the treatment of the cholestasis. I think that for the adult colleagues, if there is anybody here, it might be more tricky or it's a little more difficult, because if you have a patient that have cholestasis but have alcohol-associated liver disease or muscle with cholestasis, then you might have a mix. You might have patients that have lipoprotein X and real elevation of the LDL, and those patients might benefit for treatment. There are 2 tests. One is LabCorp that do the nuclear resonance magnetic spectrography that tell you exactly if this is lipoprotein X. And there is another test in Mayo Clinic that also give a profile of lipoproteins that you can send these 2 tests to decide what it is.
Okay, thank you. Well, and Dr. Sokol treated this patient. It was a while ago, so I don't think the IBAT inhibitors were available at that time.
So they weren't available at the time. We did a gene panel for the inherited causes. Hypercholesterolemia was negative. So we didn't send off for lipoprotein X, but really out of desperation, we thought we'd try a statin, which is the first time I've ever used a statin in a child with cholestasis, but the family understood the risks were small, the gain could have been large potentially, and our incredible lipidologist, chair of our department of pediatrics, who does all the American Heart Association guidelines, he suggested it. So I figured, well, if he thought it was safe, it's got to be safe. Anyway, we treated with Lipitor, and incredibly, the cholesterol, which was 1,000 to 1,500, suddenly was in the 500s, and the xanthomas literally melted away right in front of us. The last photo here is at 5 months of the child's hand. At 9 months, there was nothing except a few hyperpigmented areas where the xanthomas used to be. And they recovered all over the child's body. The cholesterol 500 still is elevated, but xanthomas were gone. So we were all pretty amazed that this had happened. And then, I'll just quickly go through this, growth was good, pruritus was controlled with UDCA and rifampin, neurodevelopment was normal. Next slide, I think, shows it. And then maralixabat was approved in 2021 for Alagille syndrome. Child had mild pruritus. It's in quotes because we needed that in order to get insurance approval, but occasionally scratched. And in November 2021, we switched her from Lipitor to maralixabat. And the question is, what do you think happened?
Let's get to the panel. The question.
The symptoms melted and the cholesterol normalized.
Pardon me?
The symptoms melted and the cholesterol normalized. Or got better?
It was.
We can show you.
Okay.
Just in the interest of time. So these are the serum cholesterols. And again, it was 2021 that we switched the child. So you can see that the cholesterols continued to come down onto maralixabat. And I think the next slide, this shows you her serum bile acid levels. So in 2021, prior to starting maralixabat, they were 355 micromoles per liter, which is quite high, and you could see that they were reduced by 2/3. The last one that we have recorded there was only 84, still elevated, but markedly decreased. So the xanthomas were already treated, but with this cholesterol, we don't expect this child's ever going to have xanthomas again. So we were able to get her off of Lipitor to the maralixabat.
I was curious for the panel, like, what do you think of the bile acids? Because there is some up and down, and I wasn't clear if that was how that trajectory, thoughts? Is there some natural variation?
Yes, I mean, I think the natural history of the disease, you will have variations in the bile acids. I think the message is that if they markedly improve, like, it's much better outcome for the patient. So this patient is surviving into now he's like, I don't know, 7, 8, 10. And his bile acids are less than the 102. I mean, I think many in this time we're using more bile acids, serum bile acids clinically. In biliary atresia, we know if it's less than 40, they have better outcome and longer transplant-free survival. In the PFIC, they used, there is 102, they have better outcome. I think between 300 and 200 is probably the same, but it does make a difference when it's between 200 and 100. So I do check routinely for serum bile acids. I use them in clinical practice.
I think you bring up a good point, though. The bile acids it's not so cause and effect A and B. So here, you're giving a medication, theoretically, you're losing bile acids through the gut. Your body compensates, maybe uses cholesterol to make more bile acids, and eventually you drain them. I think this is the general thought. But bile acids are tricky. We put it all on bile acids, but we were just talking before, the anti-CP drugs that were used for hepatitis B, those lead to a high level of bile acids in the blood, yet those patients don't get itchy, right? So there's a lot more nuance to this. What we're seeing is kind of probably a 30,000 view look, and we're looking at total bile acids, but there's probably many more details that can explain why this patient is doing so well, even though you see a 134 or 159, then back down to 84, but still throughout this doing so well. So I think the drugs work. The question is exactly how they work, what they're doing, I think yet to be determined.
One last question for the whole panel. Are you seeing a change in the rate of progressing to transplant? Are you already seeing that, or is that is that still sort of coming over the next few years as we have IBAT inhibitors in our armamentarium?
Yeah, I think, because the indication for using in the United States is pruritus, right? So I think we are limited. At least I'm not able to treat like all patients. In Europe, I think we'll probably get the earliest data because they are more, there the indication is the diagnosis itself. So we are only, at least my experience, we are only seeing the improvement in pruritus. And I've seen some improvement in growth as well, but again, small numbers, just my own experience. I think time will tell. I think we will know in the next few years if it really changes the outcomes. But if you think bile acids may have some role, decreasing bile acids, improving growth, potentially, I don't know.
All right, quick answers. Anybody else?
Yeah, I think that also is growth of disease progression is influenced by so many other factors. Then I think that we are depleting patients from bile acids. We are allowing them to sleep better, to cry less, to spend less calories. That is important for growth, but sometimes we can alter the absorption. PFIC patients, mainly PFIC1, have terrible absorption, and for patients with Alagille, also absorption is a problem altogether. But as the cholestasis get better, I think that we alter the whole long-term prognosis of the disease. We just need to see more patients on this treatment. That is not just for the indication of pruritus.
Wonderful. Okay, well, I want to give a big thanks to our panel today, and thank you to the audience.
Welcome back. I'm Raj Vuppalanchi. I'm a hepatologist at Indiana University School of Medicine. I would like to welcome you to this autoimmune cholestatic liver disease session. We would like to thank the sponsors for this session, Ipsen. over the last few years, we've done autoimmune hepatitis, drug-induced autoimmune hepatitis, and this year we wanted to make our session a little bit more focused on nuances in evaluation and management of patients with PBC, PSC, newer therapies for PBC, emerging therapies for PSC, and then how do you manage patients with symptoms with cholestatic liver disease in the clinic. We kept it purposefully short so that it can generate more discussion and help all of us manage our patients a little bit more personalized. To get this session started, we have Dr. Kris Kowdley. Most of you should know. If you don't, Dr. Kowdley, you need to work more harder. He is an icon in cholestatic liver disease. He's a professor of medicine at Elson Floyd School of Medicine. He has, master clinician, a great educator, and several original contributions in various liver diseases. But for the purpose of the session today, he is, unofficial king of cholestatic liver disease in the U.S., probably in the world. He has, brought most recently elafibranor through the FDA approval process. So we are very fortunate for him to be here today to give us an update on the risk assessment and treatment of patients with PBC. Thank you.
Thank you, Raj, for the kind words. I hope I don't run over, but I have a lot to cover in 15 minutes, so I'm going to get right to it. We've had some really amazing progress in the past 10 years in terms of developing prognostic models, assessing risk, finding new ways to stage the disease in PBC, and really allow our patients to look forward to a long, if not normal, life expectancy. And now we have exciting new therapies that are focusing on patient-reported outcomes and quality of life. So here are my disclosures. So one of the things that I want to start by mentioning is that our concept of risk assessment in PBC is evolving. We used to think that it was really just stage of disease. Then we developed prognostic models with alkaline phosphatase and bilirubin, and those have really gotten fine-tuned over the last few years. But several new pieces of work have come to light recently. First is racial disparities and the influence of race. And in fact, Dr. Lily Dara, who's here, just had a paper on Hispanic patients with PBC and their outcomes. Dr. Gordon from Detroit has been publishing for a while on the experience of black patients with PBC, and they can be quite different. So keeping in mind racial determinants and racial diversity is very important. There may be differences in prognosis. Age at diagnosis is now really, really important. So we know that patients diagnosed before age 43 have a very different outcome. Patients diagnosed before age 62 have a different outcome. And older patients tend to have a more benign outcome. Sex has always been an important point in PBC. We always thought that the sex ratio was 9:1. But I was recently in Italy, and the data from Europe, where there's more testing and possibly more evaluation, suggests that the sex ratio for men and women with PBC may be as low as 5:1 or 6:1, not 9:1. And there are some data with concern about liver cancer risk in men, but a very nice paper from University of Miami with Dr. Binujan has shown that in fact HCC risk may not be different in the VA population. Antibody profile is important. We know, for example, patients who have the GP210 disease-specific ANA have worse outcomes, and we obviously recognize that there are biopsy features that might be important. Incomplete response to UDCA is well recognized now as a risk factor. So I like to think about classifying risk in PBC in this manner, which is really stratifying the patient into average, intermediate to high risk, and then advanced disease, with the average risk being the patient who has a mild elevation in alkaline phosphatase, normal bilirubin, normal albumin, and has minimal or no fibrosis. Whereas patients who have advanced disease, obviously we as GI hepatologists are very comfortable with identifying who needs early referral for liver transplantation, and we're recognizing that we should be more focused on fatigue and pruritus. But the patient who has younger age at diagnosis, persistently elevated alkaline phosphatase, maybe not an abnormal bilirubin, but a total bilirubin over 0.6, may be somebody that we might consider a high risk, and fibrosis, of course. So personalization based on risk profile is becoming more important. Now, we've all known about the Barcelona criteria, Paris 1, Paris 2, Toronto, et cetera, and we have used these dichotomous models to predict outcomes based on global PBC study group, but we also know now that the development of the Globe PBC score and the UK PBC score provides continuous risk assessment rather than based on dichotomous variables such as bilirubin or alkaline phosphatase below or above a certain cutoff. And so I think that's something that's really important. By incorporating these into your clinic, into your assessment with the patient, I think we can do a much better job in risk assessment for the patient over a longer period of time, and we can reevaluate this, and patients can evaluate this based on their own laboratories. So we have dichotomous criteria and more composite, continuous criteria that once again have really moved the needle forward because we're able to risk assess patients over 10 years and longer, as opposed to the old Mayo risk score, which was really over a 5-year period and really determined patients in terms of priority for liver transplantation. And we also know now that responders do much better than non-responders, and there are several recent data that even have provided even more granular information on assessing this from real-world cohorts. So liver stiffness measurement is now well established as a risk prognosticator in PBC, and this is a lot of this has been driven by Christophe Corpechot in Paris, and it just shows you, for example, that combining Globe score, which is based on blood tests and age, and looking at FibroScan or liver stiffness measurement at diagnosis and then follow-up, can provide cutoffs that are really useful. So, for example, if a patient has less than 8 kilopascals, they have very, very good outcomes. More than 10 would put the patient at risk for moderate to advanced fibrosis, and higher than 10 would be patients who have advanced fibrosis. So we can combine liver stiffness measurement and Globe score to really evaluate clinical outcomes more effectively. Now, this is a paper we recently published, and with data shown on the right. We have these dichotomous variables that we've used historically, and that's been a criteria for entry into clinical trials, and it's been a primary composite endpoint for response in clinical trials recently with several therapies. And that's been useful, but they're really based on assessment at 1 year after starting URSO and then at periodic intervals. And we know, for example, bilirubin has a continuous function in terms of predicting outcomes, as shown on the left from a paper from Murillo Perez that was published in 2020. Shown on the right is data from a claims database and real-world evidence where we looked at risk of hospitalization, risk of liver decompensation, transplantation, so mallow, hard outcomes, however you want to call it. And we tested the hypothesis that, in fact, area under the curve might be a good way to think about stability for the patient. So this looks at what percentage of the time under observation did the patient have an elevated alkaline phosphatase and an elevated bilirubin. And as you can see, the higher the percentage of time that they were above these variables, these threshold levels, the greater the risk of adverse outcomes. Intuitively, that makes sense, but we haven't really thought about thinking about that, but it has clear implications when we're talking about therapy, because it really reminds us that we don't just test the labs once a year and not think about it in between, that we want to look at the patient over time and try to maintain them in that biochemical response for as long as possible. We have another paper that we just published showing, in fact, the relationship between treatment persistence and outcomes. And it shows that patients who have breaks in therapy and patients who have shorter duration of therapy over time have worse outcomes in terms of hard outcomes like decompensated liver disease, et cetera. And that was in elementary pharmacology and therapeutics also. So I would encourage you to look at that paper. So we know that the thinking is evolving, so we're not just testing a patient at diagnosis, waiting a year on URSO, seeing how the patient does and risk stratifying them. We're gathering data at baseline before we start any therapy, and we're trying to calculate their risk continuously over time based on a variety of different factors. And this is now starting to come out in terms of publications, where you can see on the left, baseline liver stiffness predicts outcomes, and also change in liver stiffness over time is also associated with an increased hazard ratio or risk of adverse clinical events. So again, a very sort of intuitively obvious thing, but something we're now starting to get data to show. So when you look at prediction models, they're complementary to fibrosis stage. So one of the other things that we're sort of trying to encourage people to do and trying to do in our own practice is to incorporate where is the patient in terms of their biochemical tests and what is their stage, because they're complementing each other in terms of predicting outcomes. So one way to do this would be look at the GLOBE score after a year of URSO therapy, look at changes in serum bilirubin. If it's over 0.6, that might put the patient at a higher risk category, and then use those dichotomous variables, but also consider including something like FibroScan. So with that, let me talk about treatment. So we all know URSO is accepted as first-line treatment, but many of us haven't seen these data in a while. But if you look at some of the early data with URSO, you can see that URSO was very effective in lowering alkaline phosphatase. And in fact, when URSO was approved in 1999, 97, 99, we were able to show from large cohorts that it reduced the need for transplant. And in fact, the number of liver transplants for PBC has gone down continuously since that time, but the average age of transplant hasn't changed. Again, identifying the population with severe disease that we need to be mindful about. And there's no question, it's been a while since some of you may have seen these data, but there's no question that if you look at URSO and long-term survival, there is a clear benefit in terms of hazard ratio of almost 50% reduction, more than 50% reduction with URSO therapy in terms of need for transplantation. So it doesn't just improve the blood test, it actually improves outcomes. So with that, let's move on and talk about PPAR agonists. Obviously, obeticholic acid is now not available and was withdrawn voluntarily by the manufacturer, but we have elafibranor and seladelpar, which were both approved in 2024. Elafibranor being a dual PPAR alpha delta agonist, given as an 80 milligram tablet based on the ELATIVE trial and approved in various regulatory jurisdictions, with seladelpar being a PPAR delta agonist given at 10 milligrams daily and approved now also by the FDA, the EMA, and in the UK as of last year. So here's the pivotal data with elafibranor. Here's the treatment difference of 47%. And I think it's important for us to always be thinking about treatment difference rather than just looking at the response in the treated population, because the placebo response rates seem to be variable. And these are obviously not head-to-head studies. But very impressive reduction in alkaline phosphatase of 47%, so highly statistically significant in terms of reaching those what we now call POISE criteria for the original POISE trial of obeticholic acid, patients reaching alkaline phosphatase less than 1.67 with at least a 15% reduction, total bilirubin below the upper limit of normal. And here's the rate for normalization. We didn't see this with obeticholic acid, and this is for reasons that we don't have time to get into, but clearly we're now starting to see normalization of alkaline phosphatase with PPAR agonists, which is very exciting and really showing us that we can achieve what our goal is of complete biochemical remission. You see a nice steep reduction in alkaline phosphatase as early as 4 weeks into treatment. With pruritus, you can see that with the ELATIVE trial, there was not a statistically significant difference in terms of response in patients with moderate to severe pruritus, but there was evidence from PBC-specific itch measures such as PBC-40 itch domain and 5D itch that suggested improvement with elafibranor. And this is very reassuring because, in fact, with obeticholic acid, as we all know, itching got worse. Here are the adverse events, and you can see that, in fact, these studies, both the elafibranor and the seladelpar, which I'm going to show you in a minute, were done during the COVID-19 pandemic, so that is a number one adverse event in this particular study, but they're largely GI-related with a few other side effects, but discontinuation due to adverse events appears to be not different compared to placebo, and severe adverse events seen in about 11% of the population. Now, response was a study with seladelpar, and again, a very nice difference in terms of seladelpar-treated versus placebo-treated patients with a treatment difference of 41.7%, again, highly statistically significant, so very impressive result. Here we were able to see alkaline phosphatase normalization in 25% of patients at 12 months, and a similar prompt and sustained reduction in alkaline phosphatase that occurred at baseline at 4 weeks into treatment and was sustained over therapy. With seladelpar, we did actually also observe a statistically significant difference in terms of worst itch NRS in patients with moderate to severe pruritus, and this was very impressive. And you can see that this was a change that appeared at 6 months and was sustained over the course of therapy. Side effects with seladelpar, again, COVID-19 being the number one, with a similar type of GI-related side effects that we've come to expect from the PPAR agonists to be clustered with a few other side effects that seem to be present at maybe numerically slightly higher rates than placebo. But once again, adverse events resulting in treatment discontinuation, in fact, not different and in fact lower than placebo numerically here, and serious adverse events in a comparable number of patients. So in summary, risk stratification is important in PBC. Hopefully I've given you some new ways to think about this. Should accompany assessment of disease stage. URSO clearly improves long-term outcomes. Second-line treatment, we're fortunate to have 2 therapies that are now highly effective, and we need to consider this early based on biochemical response stage and patient risk. And we have data with the PPAR agonists suggesting improvement in pruritus, which I think is very encouraging, and alkaline phosphatase normalization, which is also encouraging, and confirmatory trials are ongoing. Thank you very much. Okay, my job is to introduce the next speaker, which is Aparna Goel, who is going to talk about current risk assessment and treatment of patients with PSC. Dr. Goel got her MD from Jefferson, subsequently did internal medicine at UCSF, and GI and transplant hepatology at Mount Sinai in New York, then joined the faculty at Stanford, where she's currently an associate professor, and she has a focused interest in autoimmune liver diseases and is the program director for the Transplant Hepatology Fellowship and the GI Fellowship, associate program director at Stanford. So Aparna, please.
right, thank you so much to the organizers for having me. Dr. Kowdley did a great job giving you an overview of PBC. My job is to now switch gears a little bit and talk about the other cholestatic disease, which unfortunately hasn't had as much progress in the last few years, and talk about primary sclerosing cholangitis, so PSC. So we'll discuss the sort of current risk assessment and our management. These are my disclosures. We'll also review what our current management of PSC is in terms of medications, malignancy screening, and some extrahepatic symptoms. So just to recap, remember that primary sclerosing cholangitis is an autoimmune liver disease that primarily affects the medium and the larger sized bile ducts, as opposed to PBC, which affects the smaller bile ducts. The prevalence indicates how rare it is. 6 to 16 people are affected per 100,000 in North America and Europe. Predominantly affects males, so 70% male predominance, and ages 30 to 40. About 50% will present with symptoms initially, either intermittently or consistently at the time of their presentation, and another 20% will develop symptoms at some point during the course of their treatment, or during the course of their disease within 5 years. The most common coexisting autoimmune condition that goes along with PSC is inflammatory bowel disease, so ulcerative colitis being more common than Crohn's or indeterminate colitis. It's a very slowly progressive disease, so like cholestatic diseases often are, it can take a while to lead to the diagnosis of it. The most common test that we check to sort of monitor for disease activity is liver biochemistry, so the alkaline phosphatase. But we know that the alkaline phosphatase levels do fluctuate significantly during the course of the disease and doesn't really plot with the ongoing progressive nature of the disease. So instead, what we have found is using fibrosis markers and serum fibrosis markers, in particular the enhanced liver fibrosis, has shown better correlation when we are looking at other elastography measurements like transient elastography. So fibrosis markers probably a better marker of the progression of disease more so than the alkaline phosphatase is. We also know that there's variable levels of IBD activity. Oftentimes when the disease is early, the IBD activity tends to be a little bit more pronounced. As the disease becomes more severe and more progressive, the IBD activity tends to quiet down. There's likely a significant interplay as well between the gut microbiome and biliary inflammation, and we see that there's some biomarkers that are associated with PSC prognosis and others that exert a pathogenic effect. And some of the microbiome biomarkers that have exert a pathogenic effect might persist after transplant and may play a role in the risk of recurrent PSC after transplant. And then lastly, we are always monitoring our patients for specific clinical events, and these are important ones that we often will discuss with our patients. So the risk of bacterial cholangitis, which often happens when there's larger ducts involved, the risk of cancer, including both cholangiocarcinoma and colorectal cancer, and lastly, the risk of progressive liver disease with cirrhosis and the decompensation events that can occur with end-stage liver disease. Unfortunately, risk assessment in PSC remains quite a challenge because clinical complications like malignancy and severe biliary strictures can develop even in early stage disease. So we see it before there's cirrhosis and before there is advanced fibrosis. But we do know that it's important in terms of assessing these risks early and assessing it with our patients continuously when we're seeing them in our practice, because it helps us prepare our patients for what is to come, and it could be clinically beneficial as well. So what tools do we currently have? These are non-serum tools, so non-blood-based tools that we can use to assess prognosis in PSC. Liver biopsy, we know, is not recommended. So histology in PSC, we know, is hampered based on sampling variability, based on location of where the strictures might be and the extent of cholestasis. There's a lot of variability. So it is not recommended in clinical practice, and really the role of liver biopsy is purely in terms of clinical trials right now. Liver stiffness measurements with transient elastography or MR elastography do correlate well with progression of liver disease and should be assessed on a periodic nature in patients with PSC. And if these tools are not available, using the enhanced liver fibrosis score, like I mentioned earlier, can also correlate well with the progression of their disease. The radiographic tools that we have include MRI and MRCP. And with itself, while it's helpful to determine whether or not there's new larger duct strictures that are developing or whether or not there's signs of portal hypertension, liver dysmorphy, you can kind of, in a subjective eye or kind of looking at the scans yourself, see if there's been more progression, but there are objective measurements that our radiologists have used, namely the Anali score, to sort of quantitate if there is significant intrahepatic ductal dilation, if there is dysmorphy, if there is portal hypertension, and using that with liver stiffness measurements does actually correlate well with prognosis. And then lastly, the MRCP Plus, which is a newer tool. It's an AI-generated tool that is a post-processing tool on top of MRCP. Using MRCP Plus, we do know that this correlates as well with liver stiffness measurements, with Mayo risk scores, and with other serum markers of prognostication. So it's objectivable, it's reproducible. The question is, how accessible is it right now for our patients? But it is a tool that can be used to help prognosis. This is what the MRCP Plus looks like if you haven't seen one before. So it is quantitative metrics on the biliary tree. It gives you number and length of strictures, of dilation, of duct diameter, and you can use it with biomarkers, and it does correlate well with other risk stratification scores, like I mentioned. This is an example of a patient that had an MRCP Plus at baseline and at 1 year follow-up. And if you looked at other clinical parameters, there were no changes in liver stiffness measurement based on VCTE or biochemical measures, but we do see that there's some changes noted on the MRCP Plus. So kind of interesting to see whether or not it's actionable remains to be determined. So what other tools do we have? These are tools, these are other prognostic calculations that you can do with your patient in front of you in the clinic, as long as you have laboratory values in their clinical data. The revised Mayo risk score was traditionally the risk assessment tool that we used, and it was widely used for a long time, but it's been replaced now with some of the newer models. And that's mainly because it has very low utility in early stage disease, and it cannot predict reliably what long-term outcomes are. So the other models that we use, the Amsterdam-Oxford models, used primarily in those that might have overlap syndrome, and then the ones that are used traditionally for PSC itself are UK PSC and Presto. And I will do these in practice, usually once a year, every 2 years, to help see how my patients are marching along in their journey in their PSC. Are they relatively stable? Do I see that there is some progression in their disease? And these are readily accessible tools that you can do with your patients in the clinic. The one challenge with these tools is while it predicts the progression of fibrosis and the time to clinical event, including transplantation, these don't predict cholangiocarcinoma risk. So that remains one risk that we cannot reliably predict. Management of PSC. So medical management, unfortunately, there are no approved therapies for PSC. We rely on counseling our patients for symptoms and monitoring their symptoms. And we spent a lot of time talking about malignancy screening and other extrahepatic symptoms in our practice. What we do sometimes, what you see commonly used for our patients is ursodeoxycholic acid, and Dr. Kowdley really nicely reiterated to us how there is clear survival benefit with UDCA and PBC that hasn't been demonstrated in PSC yet. The largest study in PSC had about 200 patients or so that were enrolled and did not meet full enrollment, so wasn't able to necessarily show that there was a significant benefit. Overall, though, we do think that the use of UDCA does improve liver biochemistries, or it can improve liver biochemistries, and that if it does improve liver biochemistries, there may be an improvement in long-term trajectory. The high doses of UDCA are not recommended because it is associated with a higher risk of death and liver transplantation and potentially higher odds of colorectal cancer and PSC-IBD. This is the study of UDCA and PSC that did not necessarily meet clinical significance because of, it was underpowered essentially to show this difference, but it did show that there was improvements in alkaline phosphatase and ALT values. And what we have subsequently seen in several studies thereafter is that there is an improved prognosis in people with PSC where liver biochemistries, and in particular the alkaline phosphatase, does normalize or improve. And that could be with or without the use of UDCA. There was other studies that have looked at the withdrawal of UDCA in people with PSC. And when you withdrew the UDCA in these patients, there was a recurrence of significant symptoms, including fatigue, pruritus, increased Mayo risk score, and increased ALP. So our guidelines now recommend that we should consider UDCA at a dose that's somewhere between 13 to 23 mg per kg per day, depending on which guideline you're looking at, in those that have persistent elevations in ALP and GGT. And we might be able to see that there is some potential improvement in their prognosis. What else is available? Well, nothing else is available. What else has been studied is norursodeoxycholic acid in PSC. So these are the results from the, or interim results from the phase 3 study were discussed at EASL in last year. So this is a side chain, shortened side chain of UDCA that improves the colohepatic circulation. And it prevents amidation. We think that there's improved bicarbonate-rich layer, and it could be more cytoprotective than UDCA is. So in this phase 3 study, there were 220 patients that were randomized 2-to-1 to receive nor-urso versus placebo. And overall outcomes that they were looking at was a decline in alkaline phosphatase and no worsening in fibrosis. So this study showed that 15% of those that received nor-urso met that primary outcome at 96 weeks compared to 4% in the placebo arm, which was promising. This study is ongoing, and there are additional results that will be presented, I think, when the study completes its 192-week enrollment period. And those that were not on urso in this study did appear to have greater benefit than those that were on urso. There were in general, the safety profile that was reviewed so far indicated an excellent safety profile of nor-urso, and the rates of AEs or SAEs were similar compared to the placebo arm, and it was generally well tolerated. Antibiotics have been studied for a long time in PSC, including vancomycin, metronidazole, rifampicin, minocycline, and there are pediatric colleagues I know in the audience that will know more about this than I do, but one of the most popular studied antibiotics right now in PSC IBD has been vancomycin, primarily because of the impact that we've seen in children that have PSC IBD that receive vancomycin having improvement in their IBD. So in this study in particular that looked at 280 kids that have PSC IBD that were treated with vancomycin, 70 were treated with vancomycin, and it seemed like the likelihood of endoscopic remission of their IBD was much higher. And there were improvements, I believe, in the biochemistries as well, in terms of liver biochemistries as well. So there have been several smaller case control studies that have looked at vancomycin. The Mayo group also had an RCT with vancomycin that did complete enrollment. So I think more to come to see what the effect is in PSC. In terms of ongoing trials in PSC, unfortunately, I don't think the bexotegrast is moving on into future phases with PSC, but it did look like there was stabilization in enhanced liver fibrosis with this integrin molecule and improvement in MRI parameters. But there are other promising studies that are underway, and we are looking forward to participating. We're looking forward to seeing the results of some of these studies. So alafibranor is being studied in ongoing trials in PSC. Bezafibrate is as well. CM101 had some promising phase 2 data, and we look forward to seeing if they'll progress with phase 3 as well. In the last few minutes, I want to talk about what we do currently do with our patients. So malignancy screening. Cholangiocarcinoma screening is incredibly important. The lifetime prevalence or the lifetime incidence of cholangiocarcinoma in an individual patient is about 15 to 20%. That's a really, really high risk when you're talking to a young man that's in front of you that's 30 to 40 years old. So this is something that we have to really keep on top of in our clinic. We recommend doing MRCPs with CA19-9 annually, and we do know that regular surveillance is associated with higher 5-year survival. So there was a nice study that looked at those that had regular annual or biannual screening MRCPs compared to those that didn't, and that's likely due to earlier detection. Colorectal cancer screening, those that have PSC IBD, is recommended yearly, with colonoscopy beginning at age 15 when you're diagnosed in the pediatric population. Gallbladder carcinoma is recommended with an yearly ultrasound, and if there are polyps that are detected that are less than 8 millimeters, then to shorten that frequency to every 6 months, and then hepatocellular carcinoma screening is recommended every 6 months with cirrhosis. So with cholangiocarcinoma screening, we're getting the MRCPs. What do you do with that information? If you have a relevant stricture, meaning a stricture of the CVD or the larger hepatic ducts, it's important to follow that up with an ERCP with biopsies or brushings for Fisher cytology. Sequencing from cytology is not routinely recommended yet, although that is available at certain institutions. While it improves the sensitivity, it remains not necessarily the most specific right now, but can be added if there is concern. It's important to think about the indications for ERCP apart from whether or not there's dominant strictures and concern for cholangiocarcinoma. Oftentimes we do see that just for the diagnosis of PSC, patients are getting ERCPs, and that's not recommended and it's not needed unless there's true concern for what that dominant stricture, that larger stricture might be. So if there's new or worsening pruritus, if there's unexplained weight loss, worsening in liver biochemistries, elevated CA19-9, those are all potential indications to proceed with an ERCP. A reminder that ERCPs in our patients with PSC do carry a risk of cholangitis, so peri-procedural antibiotics are recommended. 1 to 3 days, usually at the time of the ERCP, and then 3 days following the ERCP. They also carry a risk of pancreatitis, and our advanced endoscopists, or hopefully yours, are using indomethacin or putting a PD stent to reduce that risk. And it's important to replace these plastic stents and make sure your patients aren't lost from ERCPs if they did have a stent put in. Management of extrahepatic symptoms. So I did mention earlier that about 50% of our patients with PSC have significant symptoms at the time of their diagnosis, and up to 20% more will develop it during the first 5 years of their diagnosis. The most common symptoms are pruritus and fatigue. There is a host of medications that are non-FDA approved for the management of cholestatic pruritus right now, cholestyramine being one of them, and others that are being studied, including volixibat, which is being studied in phase 2 trial for PSC-associated pruritus. And then lastly, fatigue and brain fog. This is a hard one to combat in clinic, and I don't have great tools to do this with our patients, but I will validate that their symptoms could be related to their cholestatic disease and emphasize that it's important to use pacing strategies to still be physically active. And we are fortunate enough to now have a psychologist that's part of our group, and I will refer many of these patients for therapy with her, just to, for acceptance, commitment training, for CBT as well. And I will always offer resources through a lot of our patient advocacy organizations, which I think makes a big difference for our patients. So in summary, PSC is very heterogeneous and it has variable risk of progression. The risk of decompensation or transplantation can be assessed with some clinical prognostic tools and non-invasive measures. There are no currently approved therapies for PSC, but you can consider UDCA if there's ongoing elevations in ALP and GGT values. There's many trials that are ongoing or about to start, so please consider clinical trials for your PSC patients. It's hard to sometimes fill these trials because it's a rare disease, so really think about whether or not your patients may qualify. Malignancy screening remains a cornerstone of what we're doing in our practice when we talk about our patients, and it's really important to inquire about extrahepatic symptoms, including pruritus and fatigue, when you have these patients in the office with you. Thank you so much for your attention.
For our next talk, I would like to invite Dr. Gholam. He's a Associate Professor of Medicine at Case Western. You already met him this afternoon. He's a very passionate speaker and very committed to cholestatic liver disease. Thank you.
Thank you very much. It's a pleasure to be here this afternoon. I'd like to thank Drs. Kowdley and Vuppalanchi for the kind invitation. In the time allotted to me, I'd like to talk to you about new treatments for PBC and PSC, which used to be a relatively easy task in 10 minutes, but not so much so now that we fortunately have more developments. These are my disclosures. I think Dr. Kowdley did a fantastic job covering PBC in a much more nuanced fashion. My bullet points here reflect that PBC, again, is not so rare in the proper context. It seems to be increasing in incidence, seems to be more aggressive in men, and we universally agree that alkaline phosphatase is an accepted surrogate regulatory endpoint, not so much so the case for PSC, and more on that in a second. I only show this slide also to provide some context for what I'm going to talk about next. Up until September 2025, we used to have 4 approved treatments for PBC, UDCA, the only first-line treatment, and elafibranor and seladelpar, 2 PPARs, which achieve 15 to 25% alkaline phosphatase normalization. We did have obeticholic acid, the only FXR agonist that was approved. And while this was not significantly used, at least in new patients, it did at least have the opportunity to potentially participate in some meaningful way in clinical development. And that, I think, is in limbo right now. And that will be at least part of my discussion of future treatments. As is often the case in medicine, past is prologue, right? And perhaps no better example of this than the classic Christophe-Corpechot paper in the New England Journal of Medicine from 2018. I'll remind this audience that this was a randomized placebo-controlled trial of bezafibrate in patients with PBC. The beza, of course, is a pan-PPAR agonist, which was dosed in this particular trial at 400 milligrams once daily. The inclusion criteria, which Kris went over, would be the Paris-2 criteria, and these were patients who were UDCA treated or intolerant, typical with the clinical trials that have followed. The primary endpoint was quite ambitious. It was complete biochemical response at 24 months, which means every liver test needed to be normal: alk phos, total bilirubin, aminotransferases, albumin, and prothrombin time. There was, of course, a subset analysis for alkaline phosphatase normalization alone. And as you can see here, compared to placebo, there was a very significant number of patients that met the primary endpoint, this complete biochemical response endpoint at 24 weeks. In fact, by the end of 24 months, I'm sorry. In fact, by the end of the trial, 31% of patients had met this. In fact, if you just look at alkaline phosphatase normalization, 56% of patients had met the endpoint versus 2% placebo. Pretty damn good if you ask me. Now, this is not the full context, of course. The full context is that twice as many patients in the beza arm had myalgias compared to patients who took placebo, 20% versus 10%. 5% increase in serum creatinine compared to patients who got placebo, including 3 patients who actually got significant kidney dysfunction. 2 had stage 2 CKD, 1 had stage 3 CKD by the end of the trial. And of course, 3 patients who had AST greater than 5 times the upper limit of normal, of which 1 needed glucocorticoids, and all 3 were withdrawn. So there's no magic pill, of course, and this is one such example. But clearly, one would argue that these are fairly encouraging findings in this setting. Of course, the future of beza was going to be its combination with the FXR agonist obeticholic acid, and this, at least for the foreseeable future, is all the data we're going to be seeing. This was presented in abstract form at the AASLD, at EASL in 2024. 4 arms, beza 200 milligrams immediate release, OCA 10 milligrams with beza 200 milligrams, beza at 400 in a sustained release form, and OCA 10 milligrams with beza at 400, randomized 1:1:1:1, given for 12 weeks, an open label extension out to 96 weeks, which was the context of a phase 3 trial. None of this is currently ongoing. If you look at the data at month 6, you will see that alkaline normalization was achieved ranging from 37% in the immediate release 200 milligrams beza arm, all the way up to 61% in patients who received the higher dose of beza at 400 milligrams and OCA at 10 milligrams. If you look at biochemical remission, the more ambitious endpoint of not only normalization of these parameters, but also more than 40% reduction in alk phos, GGT, ALT, AST less than upper limit of normal, and total bilirubin less than 0.6 upper limit of normal. That was achieved, again, in roughly the same percentage of patients, anywhere between 32% to 67%. Of course, there were some side effects, and a recurrent theme here is anytime you introduce beza, you potentially introduce some increased risk of myalgia, which you can see in the beza arms to your right at 10% in the 400 milligram arms, and I believe 6% in the combination of OCA and beza. Now, these are very small numbers. Each arm has about 19 patients. There's also some mitigation of pruritus in the beza context, where patients who took beza had less itching. This, by the way, was shown in a separate trial called the Fitch trial for fibrosing cholangiopathy, so makes biological sense. But the upshot of all this, and why I'm mentioning this even though it may go nowhere, is that if you look at normalization of alk phos, this is by far the most ambitious and most optimistic estimate of the result of an intervention that we've had in the BISA 400 OCA 10 group. There are, of course, other mechanisms of action. I think most of us think that if you use a PPAR-driven mechanism, such as the pan-PPAR-BISA or some of the other drugs in development, you're probably going to reach a ceiling where you cannot improve this beyond that, and so novel mechanisms of action are very much needed. This is very much an out-of-the-box way to look at this. This is a drug that has, this is an investigational agent that has received orphan status, and it is relying on a proprietary technology whereby you can encapsulate many different antigens. This is not just being done for PBCs, it's done for myasthenia gravis and other diseases. And by doing so, you actually induce energy to potential immune responses that potentially damage cells targeted by various immune-mediated diseases. This seems to work both on humoral immunity, so B cells, and also cell-mediated immunity. And this is what this CNP-104 drug is. This is a drug that targets, in this particular case, PDC-E2, which clearly we think is significantly implicated in the interlobular bile duct injury that occurs in the setting of PBC. These are day 120 data. This was presented, I think, a year and a half ago now at EASL. And if you look at the data here, these are infusions which were basically given as a loading dose and an 8-day dose. There are 3 doses, 4 milligrams per kilo, 8 milligrams per kilo, and placebo. The proof of mechanism of action basically relies on target engagement. If you look at Th17 pathogenic cells, which are thought to be very significantly implicated in the pathogenesis of PBC, that clearly declines at day 120. Notice that after the patient stops treatment, by day 180, you have a rebound in these cells, which suggests that this was indeed a byproduct of receiving the medicine. There's also some liver stiffness data, which I think look less convincing in my opinion, whereby you have at least a stabilization or maintenance of liver stiffness over the 120 days of the conduct of the study, and this does rebound up after the drug is discontinued, or the investigational agent is discontinued, versus placebo, which actually continues to slowly march up over time. So promising data, but obviously much more needs to be done. PSC, as Dr. Goel mentioned to us, is a progressive cholestatic liver disease, typically in a young person. Over 2 decades of life, a patient might progress to the point where they might die or need a liver transplant. There is no proven treatment. There's a significant percentage of patients who have IBD. Quality of life is significantly impaired. And most importantly, regulatory endpoints are in flux. These include alkaline phosphatase reduction, some markers of inflammation and fibrosis, histology, and composites, including imaging like MRCP+. Another drug that Dr. Goel mentioned to us, and I'm not going to dwell too much on this because she covered this very nicely, is norucolic acid, aka NOR-UDCA. This is a drug that is primarily working on both cholangiocytes and hepatocytes through a hypercholeratic effect, which downstream induces a variety of anti-proliferative, anti-fibrotic, and anti-inflammatory effects. This is, of course, a synthetic engineered bile acid, so one would expect some degree of similar profile to UDCA, although potentially that can be mitigated by the engineering of the drug. I think Dr. Goel mentioned most of this, so I won't spend too much time on this. This is an ambitious program, which is going to span all the way out to 192 weeks. I'll show you the 96-week data with the primary endpoint of partial normalization of alk phos, less than 1.5 times the upper limit of normal, and no worsening of a disease stage as assessed by a biopsy based on Ludwig staging. So these patients ideally were supposed to get a biopsy at baseline and another one at 96 weeks. This is a true intention to treat analysis. So if you did not have a second biopsy, you would be actually considered a non-responder. And as was shown just a few minutes ago, 15.1% of patients met this composite endpoint versus 4% for placebo. And that basically was statistically significantly superior to placebo. Pretty good safety profile for this once a day, 1,500 milligram per day dose. Rate of adverse events comparable to placebo, and overall, as far as we are told, well tolerated. Elmwood is a randomized double-blind placebo-controlled phase 2 trial. The data are now published in J Hepatology as of last month. This paper by Dr. Levy basically outlines not only the inclusion-exclusion criteria, which are pretty standard. Of course, you could not have decompensated cirrhosis. You could not have a very high ALT. You could not have evidence of portal hypertension or severe, at least a platelet count less than 100,000. Randomization in a 1-to-1-to-1 fashion to placebo, elafibranor 80 or elafibranor 120. The data we're going to show are out 12 weeks, and there's an open label extension trial of elafibranor at 120 milligrams once a day out to 96 weeks. The primary endpoint was primarily safety here, but there are secondary endpoints, including change from baseline in biochemistries, non-invasive markers of fibrosis, and there are a number of exploratory endpoints, including assessment of itching. And if one looks at the 12-week data, the relative change from baseline in alkaline phosphatase panned out at both the 80 milligrams and the 120 milligram doses. As you can see, the decrement below the baseline is about minus 25 and minus 44.7 for both doses. An alkaline response, according to threshold reduction, was significant across the board. About 69% at the higher dose had a reduction more than 40%, about 56% less than 1.5 times the upper limit of normal, and about 17% actually normalized ALK phos on this regimen. The last agent that I'd like to talk to you about is a CCL24 target known as CM101. It is known that CCL24, through primarily recruiting bad actors into the liver, macrophages, and others, can actually impact histology, drive inflammation, and potentially fibrosis. And this incredibly busy slide basically highlights much of this, including picuoserous red staining, which you see on the right, that shows that in an animal model, if you abrogate this, you can reduce fibrosis. You can also reduce the number of macrophages that are recruited to the liver, and you can also potentially reduce bile duct proliferation, which is an indication that you're getting less injury. And in fact, there is a study called the SPRING study. This is now published by Professor Bolus and colleagues in the American Journal of Gastroenterology in 2025. And I'll show you some highlights here in the interest of time. There is a decline in liver biochemistries, a modest one, but nonetheless a decline across the board, AST, ALT. This typically seems to happen at the higher dose, not so much at the lower dose of this. This is given either at 10 or 20 milligrams per kilo per body size. It's given every 3 weeks intravenously, which means that if you take it for 15 weeks, you're going to get injections every 3 weeks. If you look at liver stiffness, there's also a modest decline in liver stiffness during that short period of time. And again, this is primarily happening happening more in a dose-dependent fashion at the higher dose. And this is an open label extension set of data at 48 weeks. And what it shows is that, again, at the higher dose of this, there is stabilization and non-invasive fibrosis parameters, including ELF. And this seems to be much more pronounced in patients who have at least advanced fibrosis. So if you took all comers, there wouldn't be as much of a decrement or stability of fibrosis. But if you took specifically patients who had more fibrosis, and you compared them on the last panel on the right to historical controls, these are taken from the Corpus-Shaw paper in 2014, where they looked at the progression of fibrosis in PSC. You can see that at the 10 and 20 milligram per kilo doses, you are faring better in terms of evolution of fibrosis compared to the historical data. I'm going to end here, and I'm going to thank all the folks who were kind enough to share slides with me, Kris Kowdley and Gideon Hirschfield, Jason Barnum, Alison Barnes, Megan Smetana, Paul Peloso, and Agnes Costello. Thank you very much.
I'm going to be talking about symptom management, particularly pruritus and fatigue, while the patient is sitting with you in the clinic. These are my disclosures. Cholestatic liver disease is something that's a little bit different from your other chronic liver diseases, where symptom management is part and parcel, particularly with primary biliary cholangitis. It's challenging because the pathophysiology is not very clear, and it probably is multimodal. I'm going to talk briefly about assessment tools, practical management algorithms, some treatment options, and then some future directions. Symptom burden in cholestatic liver disease, while many of us are familiar with hepatic manifestations, assessing the biochemical response and severity of liver disease, portal hypertension complications, PBC, for that we also are, pretty familiar with other extrahepatic manifestations, particularly Zika syndrome, looking for hypothyroidism, other autoimmune diseases, and fat-soluble vitamin deficiency. We are increasingly being challenged to address fatigue and pruritus and objectively quantify the severity of these symptoms, particularly with second-line treatment options showing improvement in these symptoms. So we are more attuned now to address these. And then there are a lot of symptoms that PBC patients describe, and they are vague, they are challenging, and difficult to quantify and document in the clinic chart, because sometimes we don't have a particular designated word to describe those symptoms. With regard to the proposed mechanism of itch, it's very challenging, but I'll walk you through this. Cholestatic liver disease, obviously bile salts, bilirubin. There's peripheral sensation in the skin, and that's carried through peripheral nerve fibers to the spinal cord, and then it is carried to the central nervous system. But completely separate from that, there is endogenous accumulation of histamines, opioids, and then other neuropeptides that can directly affect the brain or through the peripheral nervous system. And as such, you have autotoxin, you have histamines, IL-31. So if the pathophysiology of itch in a PBC patient is primarily through total bile acids or bilirubin, you may have efficacy with drugs that reduce these. But if the mechanism is increased endogenous histamines, you might have better response with antihistamines. And if it is IL-31, which is completely separate from the histamine pathway, you may have to look for a drug that decreases. And there is a drug that is currently approved in some of our refractory itch patients. We do send the patient to a dermatologist for use of that drug. It's a monoclonal antibody that decreases IL-31. And then there have been some trials decreasing, using the mu opioid activity blocking at the central nervous system. And if that is the predominant mechanism for your patient, that might work. So there are many things that are happening. And as you see in the figures, these can fluctuate over time. And these also, can explain the placebo response that can happen in a clinical trial. How do we measure itch? In the clinical trials, the best tool is the worst itch numeric risk score. This is what the FDA is looking at if they want to approve a drug and to show that there is improvement, because it's reliable, it's valid, it has been tested and retested, and it captures the patient experience of itch. How does it work? On 0 to 10, you have an 11-point scale. And you ask how would you rate your worst itch in the past 24 hours, and these are the numbers. And then you have the 5D itch scale, which is going beyond the itch severity and how this itch is affecting the overall dimension of the patient and their performance. So if we were to use WI-NRS is the best score, but again, this is when the patient is presenting to you in the clinic and you're asking in the last 24 hours. It does not capture last month, last 3 months, or last 6 months. So it is a one-time capture. With regard to the treatment, luckily we have the second-line treatment options that address the liver-specific biochemical response, but also improvement in the itch, and this has been shown by Dr. Kowdley. Here you see the numeric risk score over time, and you have the treatment arm and the placebo arm, and there's a difference in the seladelpar treatment trial. There is a difference between the placebo and the treatment arm. And what is clinically meaningful, generally 3-point decrease in the numeric risk score is considered clinically meaningful change. And you see this hitting the 3 points with the treatment arm and the placebo at 1.5. And you also notice that you see the biochemical response happens within 4 weeks to 6 weeks, but you see by the time you see an improvement in the numeric risk score that is clinically meaningful, it can take up to 6 months. So you might see an improvement, but for the full clinically meaningful response, there is a lag from the biochemical response to the symptom response. So you might want to tell your patients that yes, you will continue to see the benefit. Wait until the 6-month time point for us to fully realize the benefit of second-line treatment option. And there's another study that shows that where exactly is the improvement in itch over time. This is the elafibranor data. They could not show the statistical significance with the WI-NRS score, but you see with the treatment, the score improves, and over time, the differentiation was still there, but it did not meet the statistical significance. And if the same itch as measured by the 5D itch scale, there was a statistical significance. So sometimes you don't understand whether it is the instrument that did not perform well or is it the drug that did not perform well. So I do think based on the mechanism of action, both drugs do work, and it is up to the patient with regard to what is the actual pathophysiology of itch that is happening in that patient. I did want to talk about IBATs. Thank you, Dr. Gholam. I asked him to spare this topic for me because I wanted to have this hook, because these drugs are now going to be an option for us sooner than later, with IBAT being evaluated for cholestatic itch in adults with PSC and PBC. So the concept is, you intervene in the enterohepatic circulation, you block the bile acids from being reabsorbed, so you decrease the bile acid pool. This is the phase 3 trial for cholestatic itch using linerixibat. You see the WI-NRS score decreasing 3 points, which I think is clinically meaningful, and it is statistically significantly higher than the placebo, and this continues to be persistent over time, maintaining the statistical significance. The data has been submitted to the FDA. The PDUFA date is March 24, so less than a month, we may have this treatment option available to us for use in cholestatic itch. Whether it will be only for PBC or PSC and PBC, I'm not clear, but we can certainly, evaluate for cholestatic itch. So, what are the nuances in how we are going to use in the treatment response? So, this is the WI-NRS score at baseline at week 24. These are the change in the different PBC 40 domains, and we see that there is some difference that is maintained over time. These are the side effect profile, and you see that diarrhea is what you would expect with IBAT, but there is some noise with regard to the liver enzyme elevation that required the drug to be stopped. So we have to be a little bit familiar on how safe we can use it and what kind of monitoring we need to be doing with regard to the IBAT use for cholestatic itch. And then Dr. Kowdley already mentioned that the baseline total bile acids are not predictive of treatment response. So, how do we go about using this? So this is what I'm thinking. If a treatment naive PBC patient shows up, obviously first line is UDCA, and you evaluate the biochemical response, whether you do it at 12 months or 6 months, and the cutoff you use for alkaline phosphatase 1.5 or 1.9 if it is a 6-month evaluation. And if there is no biochemical response and there is itch, it's a no-brainer, you go to the second line treatment. And then if there is biochemical response, but the patient continues to complain of itch, do you go to second line even though alkaline phosphatase is normal, or do you go into stepwise pharmacotherapy that we all do, have been doing for several years, or you go to an IBAT inhibitor to add on to your UDCA, and then second line, and then an add-on IBAT. There's not much data on the combination of second-line treatment, PPAR and IBAT together. They are different mechanism of action, so there may not be much overlap, but I don't know the safety aspects of it. The other thing is I already talked about, you are measuring at the time of your clinical encounter, but you are not necessarily measuring what's happening to the patient over time. So there is this group that has done an app-based approach where the patient is continuously entering the symptoms over time. And interestingly, the number one is fatigue, joint pain, concentration difficulties, abdominal discomfort, dry eyes, dry mouth, cramps, swollen feet, and then, it's severe liver disease. You can have some complaints of jaundice, but itching was somewhere around 60%, but there are several other symptoms that the patients actually are debilitated from that are beyond itch and fatigue. Our group at IU has an app that is being used, but we are optimizing it for cholestatic itch, so it is possible to use app-based. If I made pathophysiology of itch very confusing, forget about understanding fatigue. It is very complicated, but I'll make it very simple. There's central fatigue, which is lack of intention, memory impairment, sleep quality, and daytime somnolence. And then there is the peripheral fatigue, where there's actually fatigue in the muscles. Maybe there is disruption in the mitochondrial pathways causing inability to exercise and things like that. Measurement of fatigue is even more challenging. There are several tools. Some are paper. Some patient can mark by themselves. Somebody has to deploy the instrument, and some are computer based, but most are generic tools. They are not necessarily customized to cholestatic liver disease. So treatment of fatigue, at the most we can do what we think within our reach, which are the contributors to fatigue, hypothyroidism, since it is common in PBC. The one thing that I'm very big is the sleep apnea, or ordering a sleep study and seeing if it is contributing to the fatigue, and then medication-induced side effect, things like that, sleep hygiene and pain. There's no drugs that are currently approved for treatment of fatigue in PBC or PSC or any liver disease, but there are some small studies where we use off-label modafinil. But there is increasing interest in exercise program, CBT, particularly those where we talked about peripheral fatigue, so stimulating the muscles, converting from anaerobic to aerobic maybe can help with the fatigue. There is some data with elafibranor on fatigue. It did meet statistical, I don't think there's a p-value, but this is not a key secondary endpoint, but there is difference in improvement in fatigue with elafibranor, but there's no data on seladelpar. With regard to safety slides, fair balance talk, it pops up randomly, but this is the safety on seladelpar. We might want to talk about, fractures, CK elevation with regard to the second line, but we'll do that at the round table. This is the elafibranor. With regard to the treatment of fatigue, I do recommend exercise regimen, particularly aerobic, and then anything that can improve daytime somnolence over cognitive function and quality of life. We have worked with Punita Tendon in Canada, referred some patients to yoga and Pilates and any kind of just get up and start walking. It's easy for us to say, but they may be very challenged. There is increasing emphasis on how we manage patients with PBC, particularly symptom management. There is a value in seeing the patient for an in-person visit compared to tele visit. This is something that we are increasingly conscious about, asking for an in-person visit for patients with PBC. Talking about Sika syndrome, getting a liver stiffness, and then if cirrhosis, ultrasound hepatoma screening. We always encourage them to join a peer support group, PBCers, so they can share their experiences with other patients suffering from PBC. We don't have a standardized way to capture these symptoms, but we are planning to deploy an app-based capture of symptoms for patients with PBC. So where I see this going is individualized therapy. Yes, we all know how to do biochemical response. We are pushing it to complete normalization of alkaline phosphatase, bilirubin less than 0.6, looking at 6 months versus 12 months, LSM at baseline and follow-up and combination of LSM with GLOBE score, and then asking about symptoms, and then, when we intervene, documenting an improvement with the second-line treatment. But we are still struggling to figure out how best to quantify these symptoms, and we don't have great biomarkers for itch and fatigue. So with that, we will get to the roundtable. Thank you.
So I'd like to invite the speakers to the stage here. So great. And hopefully we'll have some time for discussion. And I should have introduced Raj properly. So he's a professor of medicine, director of hepatology at IU, and publishes in many areas, including DILI, cholestatic disease, and MASH. So thank you, Raj. Sorry for not giving you the props there. So we have some time for Q&A. I'll start off by asking Aparna about PSCs. A lot of questions, very few answers. But one of the things in PSC that I think is really interesting is that itch is a real issue in patients with PSC, and I think we don't think about it much because we're so concerned about cancer surveillance, colon cancer, gallbladder cancer, bile duct cancer. The patients are overwhelmed. But in fact, itch is, not uncommon in PSC. We just published a patient survey that was sponsored by Miram, but really from patient groups all over the world, of over 400 patients. Now, this is self-reported, and surprising, over 90% of patients who had this PSC patient self-reported that they had itch at some point or another, with a significant percentage reporting bothersome itch. And another paper from a multi-center study in the UK just came out in Journal of Hepatology suggesting that 25% of patients with PSC actually have itch that we would consider moderate to severe, NRS 4 or more. So I want to ask everybody really on this panel about whether they were impressed by these data, whether you think itch is an issue in PSC, and whether there would be a role for IBATs in PSC as well. And there is a trial that's ongoing with volixibat for PSC-related itch and also for PBC. So I'll just start with you, Raj, and have each of you talk about whether you think itch is something that is a real issue in PSC.
It is real for those who have it. And when those patients complain, they are usually difficult to manage. But we all have our own formulas on how we go about, algorithm-wise. I do get tempted with off-label, fenofibrate, but I do worry about drug-induced liver injury in those with elevated bilirubin at baseline. So, I do a variety of things, but I am looking forward to IBATs if the FDA is going to approve for cholestatic itch versus PBC itch only. So that we'll know in a month.
To answer your question, your data is very impressive. Good job with your study. I think itch is very prevalent, it's underreported, it's underasked, and I think that's true in all chronic liver diseases, especially in cholestatic liver diseases. We saw it in PBC with what we thought the prevalence of itch was, and then target PBC data came out indicating it was very prevalent. And I think similar to what you guys are finding when you did your survey is when we do validated instrument tools, those are taxing, those can take time to fill out. I think that sometimes what the true prevalence isn't necessarily easily reported in those instruments. But when we ask our patients, I think 7, 8, 9 times out of 10, they will say that they have experienced itch at some point. So I believe it. UDCA and PSC doesn't usually treat the itch, so if we are going to use it, it's not going to do much for it. We do need to address it and treat it differently. So we'll see with elafibranor and as it gets studied in PSC how that might impact itch, but I think also looking at how the IBATs do in PSC. I think the interesting thing with the IBATs in PSC is a lot of our patients with PSC have IBD too. So the risk, the adverse effects of diarrhea, I think we have to be kind of mindful of also in that population. But I am looking forward to it.
Yeah, I think it's not so much just underreported, but also undervalued by patients in terms of what the decrement in quality of life really is. I guess a classic example that jumps at me is a patient who has been itching all their life. I diagnosed them with what I think is adult inherited cholestatic liver disease. I prescribed them an IBAT inhibitor, and when the patient was called 2 days later, the patient said, I did not realize that I had not been sleeping at night for 20 years. This is the first time in 20 years that I actually put my head on the pillow and woke up at 7 in the morning. And so I think it's the resiliency of the human spirit that people get used to horrible quality of life and don't really want to make much out of it. And we probably should do a better job of eliciting this history in a patient as opposed to just generically asking about itching.
Yeah, I think that's a really good point, especially now that we have potentially IBATs available in the clinic, and since genetic testing for cholestatic disorders is now available to us really free, made available by some of the companies that have medications, we're seeing more and more patients that have PBC and MDR3. Or some other sort of variant that could be contributing, and potentially that would be an indication for considering therapy. And I think the fact that we are now able to incorporate patient-related outcomes and symptoms is, really, really great. So, Aparna, you're still in the hot seat. So I'm going to ask you a couple of questions about PSC because I'm still not sure that we're doing the right thing. For purely reasons of maybe treating myself, have taken the tact of doing alternating MRCPs and ultrasounds every 6 months in non-cirrhotic patients with PSC. Obviously, we know about the gallbladder polyp issue. What's your approach to surveillance, and how do you kind of read the recent data about prevalence and outcomes with surveillance, cancer surveillance and PSC?
Yeah, so for newly diagnosed patients, and I agree with you, I don't know if I'm doing the right thing either, but I'm following kind of what the guidelines are saying. So for newly diagnosed patients, I do initially start with annual screening. So I'll do it once a year, but there is some concern, once a year MRI, MRCP with CA19-9 for cholangiocarcinoma screening. There is some data that maybe gadolinium has long-term impacts. We see it depositing in the brain. We see that maybe there is some risk to doing, if you start at the age of 25 and you're doing 40, 50 MRCPs or MRIs, then that could be a problem down the line. So if I have seen that there's stable disease, meaning that there's no new biliary strictures, liver tests are normal, ELF score is relatively stable, or transient elastography scores are stable, I do sometimes talk to my patients, share decision-making, and space it apart to 18-month, 24-month intervals if I think they have relatively stable disease. I haven't missed a cholangiocarcinoma yet by doing that, but it does make me nervous. I still do the CA19-9s, and I still will get the ultrasounds in between. So just in case there is something small that pops up, then I would follow it up with an MRI. And then gallbladder polyps are a challenge. It still is recommended to do annual ultrasounds for polyps. The MRIs are not sensitive enough to detect, smaller polyps that are like that. So our radiologists do still recommend it, and we are still getting the annual ultrasounds done. And then colon cancer screening is, for PSC-IBD, it's pretty straightforward once a year. But if you do not have IBD and you only have PSC, there's no great data to support what we should be doing. What I offer is usually every 3 to 5 years, but the actual, from a population level, it looks like the incidence of colon cancer and PSC when you do not have IBD is actually probably similar to the general population. So you may be able to follow what the general population guidelines are.
Pierre, is that also your approach? Do you have a different approach?
Yeah, perhaps a less targeted approach that I use is every patient who has evidence of stricturing disease, on imaging, I do alternating ultrasounds and MRCPs every 6 months, and I check an AFP and a CA19-9 every 6 months. Maybe that's overdoing it, but that's what I've been doing. So, yeah, and I don't know if I'm doing the right thing or not, but I don't know what else to do. I'm open to suggestions. So.
Well, a little bit different at IU is we have MRCP Plus, and we've been doing that for last 2-3 years. For a new diagnosis, I'm a little bit more aggressive with the MRI, MRCP, because most cholangiocarcinoma diagnosis occurs early on. But after a certain time, if the alk-phos is normal, I get away with the ultrasound.
Great. Well, I thought we had more time for questions, but we're already past our time. So we'll be around. I'm sure that many of you have patients you want to discuss with us or anything else, or tell us how you might be handling things differently. So thank you so much for this session. I want to introduce, thank you. I want to introduce Dr. Ejaz Ahmed from Stanford, who is going to do a wrap-up.
Hello, everyone. We don't have time for wrap. Just wanted to thank a few people, starting with Dr. Bacon. I also interviewed with him when I was a fellow, and he gave me some very good advice. So a great tribute that we gave to him this morning, and thanks to his family for lending him to us. And I'll wrap up with one more thing. We won't have this meeting if Danielle and her group would not organize a meeting like this in the first place a few years ago in the beginning of COVID. So just a round of applause for them. And then they really do work very hard to find the venue, and the steering committee takes the credit. And I think they deserve a lot. And the dinner is right outside, and this is a wrap-up, but the first day is not over yet. You just come right back in for the last talk of the day. And then we'll end the day, and we start early tomorrow morning. Thank you so much for attending this meeting.